Hello, hello, hello. Hi, everyone. Hello. Hi, welcome to Dr. Mercy, Q&A with Dr. Mercy, excuse me. Hi, everyone. Hope everyone can see me. Hello, hello, hello. Let me see if anyone's coming in. Hi, everyone. Hello, hello, hello. Okay, I'm starting to see people. Hi, welcome to Q&A with Dr. Mercy. I'm Dr. Mercy. And I am happy to be here. I'm happy to be here on this live show. I hope you guys are having a wonderful Friday. I'm having a wonderful Friday. And let's kind of dive in. Before we dive in, actually, I always like to ask, um, where are you guys calling from? Hi, Sophia. How are you? Hi, how are you? Hello, hello. Hey, Jackie. How are you? Hey, Roslyn. Hey. Hey, Cheryl. How are you, Cheryl? Hi. Where is everyone viewing us from? I would love to always know that. Oh, hey, Doctor. Hey, I was saying, hey, Dr. Mercy. I'm Dr. Mercy. Hey, Gwendolyn. How are you? Hey, Barbara. I'm happy to have you too. Okay, South Carolina. Oh, Austin. Awesome. Georgia. Okay, Cleveland, Ohio. Another South Carolina. That's awesome. Louisiana. Okay, okay, right next door. Bloomfield, Connecticut. Awesome. Hey, everyone. Hey, Simone. Hi. So, and Las Vegas. Okay. Las Vegas, Latanya. Hi. How are you? Houston, right where I'm at. Hey, neighbor. Hello. Hi. How are you? Well, thank you guys for coming in. I really appreciate it. So, just want to dive into our topic and India. Okay. All right. Well, welcome. Hi. Okay. And Brazil. Ooh, Rio de Janeiro, Brazil. I always want to go to Brazil. So that's awesome. Well, and Tulsa, Oklahoma, up north. Hi, how are you? So I wanted to just dive into our topic for today, and that is a few things that we doctors wish people knew when it came to coming to the hospital. Okay. So how did I or why did I want to speak about this? Well, the reason being is, I yes, I do Q&A with Dr. Mercy. Usually every Fridays around this time, usually on occasions, I'm not able to, but for the most part, I'm here. And if I'm not here, I'm working, and I work as a night doctor. So, or they call us nocturnist. I'm internal medicine trained, but I work in the hospital. And as a nocturnist, what my job is actually is to be the night doctor, admitting doctor for the hospital. I work in a very small community with a very small hospital. And so, what ends up usually happening is the emergency room doctor would see someone who comes into the hospital. They'll make their assessments, see whether or not they need to be in the hospital, and if they decide that that person needs to be admitted to the hospital and needs to get treatment in the hospital and can't get treatment at home, then they call me up, and then I'm the one who now has to admit them to the hospital. And so that would involve me seeing you, and that would involve me now trying to start the plans that include your treatment. So a lot of times when I'm doing that, I realize that not everyone knows exactly what to do when they're in the hospital or what is being done. So I kind of wanted to use this opportunity to kind of give like an orientation of certain things that you should expect in the hospital, certain things maybe are no-nos, just so that when you do go to the hospital, you can be able to feel aware of your surroundings and be able to know what you can do, what you maybe shouldn't do, so that you can have a speedy recovery. So I just wanted to talk about that, and here are just some of my tips that I wanted people to just know. So the first tip or first discussion that I wanted to say is, what's the point of the night doctor? So a lot of times, this is something that I wish people knew. A lot of times in the hospital, or recently in the hospital, they've been having it where they would have like day doctors and night doctors. And these are, so the day doctors or day hospitalists are the hospitalists who come into the hospital to take care of any patient that gets admitted to the hospital. Okay, so anybody that gets admitted, you are assigned a doctor, right? And that doctor is like the main leader of your care. But depending on what type of condition, or that you are being treated for, they may refer for other specialists to join in your care. So let's say someone comes in with a heart attack, for example. The first doctor that you'll be met with would be a hospitalist, and they'd be the ones to actually admit you to the hospital. So they'll come in, or be like, welcome, thanks for, not thanks, but welcome. Let's get to know more about what's going on with you. Okay, it seems like you're having some heart trouble. I'm going to call on our heart doctor to come by and see you. And then while they're dealing with your heart issues, I'm going to be dealing with everything else. So if you have diabetes and you normally take insulin, or you take oral pills, I'm going to be the one that will order those pills so that you can get them. I'll be checking your blood sugars just to make sure that your blood sugars stay normal while you're in the hospital. It looks like you have thyroid issues. I want to make sure that you are still on your thyroid medications while you're here. And why don't we just check your thyroid level, make sure that your thyroid hormones are still normal. So the hospitalist is the one that just looks at the overall person, while the specialists just come in and do just their own specialized thing. Just think of it as, how you have your family doctor or your primary care doctor that you go see. They're the ones who are in charge of your overall care. But on occasion, if you go to the family doctor, they may say, you know what, let's refer you to see a cardiologist. You were talking about you're having a little heart pains left a little bit. So let me refer you. Just like how they refer outside, that's how they do it in the hospital as well. Okay. So that's the purpose of a hospitalist. But lately, back in the day, actually, before, the hospitalist used to be your family doctor. You would have your family doctor that you see in the clinic, and then when you needed to be admitted to the hospital, right, they would be the ones that would come into the hospital and greet you. But recently, because there's just so many people who need care, the family doctors are not able to go to the hospital like they used to do. And so you see them, having to unfortunately relinquish that part of the care and just stay in the clinic. And so they needed people who could, take the place of what they used to do in the hospital. And that's why there was the new career called hospitalist, because those hospitalists are doctors who are mainly work in the hospital. A lot of us don't have clinics. We just work in the hospital. But within a few years, there was this push to not only just have doctors that work in the hospital, but now separate them. Who works during the day? We call this day hospitalist, and who works in the night? We call them night hospitalists. Back in the day, it used to be that hospitalists, they would each take turns or be on call to see who would work in the night. Now it's, okay, there's an actual field called a nocturnist, which are night hospitalists, and I'm one of them. So as a night doctor, I wanted to just kind of bring some of the roles of what the night doctor does so that you won't feel confused, because I feel like a lot of people feel confused when they have to meet a night doctor. So the night doctor, the purpose of the night doctor is to make sure that when the day doctor goes home, the night doctor comes in and makes sure that everything is a-okay. So let's say you were admitted to the hospital because of a pneumonia, for example. Okay, you were admitted during the day. Okay, the day doctor came in and said, hey, we saw on your x-rays, it looks like you have some pneumonia. Let's get you on some antibiotics and oxygen, and then we'll go from there, right? So you're feeling good and you're getting better. And then at night, you're like, ooh, I'm getting some heartburn, And so you call your nurse and you say, hey, nurse, I have a little bit of heartburn. And your nurse is like, oh, well, let me call the doctor. They're not calling the day doctor because the day doctor has left. They're calling the night doctor. And so the night doctor gets the call and says, oh, okay, so, that patient has heartburn? Oh, no problem. Let me order some Maalox. And so next thing you know, the nurse comes in and you have Maalox. Well, that is our purpose. Our purpose is for anybody who's in the hospital, if there's any needs or concerns in terms of urgent concerns, we address them. But what we cannot do, and a lot of people get confused, is we don't know your treatment plan as the day doctor does. We may read the notes and say, oh, it looks like this patient's being treated for pneumonia, but we were not involved in your treatment plan. So a lot of times, and I see this all the time, a lot of people would want to know at 10, 11, midnight, hey, can you call the doctor? I want to know what's going on with what's going on with me. I want to know what their plans are. And so the nurse comes and calls me and says, hey, so-and-so wants to know what is their treatment plan. And a lot of times I'm perplexed. I'm like, well, I don't know. I'm just here just as a covering doctor. And so I always have to go into their rooms and say, look, I'm so sorry. I don't know what your treatment plan is. I can read to you what the notes say, but I can't tell you as your primary doctor because I am not the one who is mainly in charge of your care. A lot of times the best way to know what your care is by talking to the day doctor or the primary doctor that's taking care of you at the time. Not everything everyone can type. There's certain things that, yes, they write in their notes and certain things they don't. If they plan on letting you go home tomorrow, a lot of times they don't write that in the notes. So when some people say, oh, well, when do I get to go home? I'm like, I don't know. I'm sorry. I just know that they said that they're taking care of your pneumonia, and it looks like you were on oxygen. Now you're not. So, and you're still on the antibiotics. I guess that means that maybe there's a chance you'll be able to go home, but I'm not quite sure. So I'm saying all of this to just say, be very cognizant of who is taking care of you. When you first come in, say, okay, who's the lead doctor on my case? Who's the one I should talk to when it comes to my plans? Then be cognizant of that so that anytime you have any questions, you know who you need to go to. Okay, so the next tip that I have is always bring your medication list, your current medication list. And people may be like, why? I whenever I'm sick, I go to this hospital all the time. You should have my list on the computer. And yes, that may be the case, but the issue is, in which I wish that it gets changed. The issue is currently in this current healthcare system, there's a lot of different softwares that each hospital has access to. Let me repeat that again. There's a lot of different softwares that hospitals can use to use for their online medical records. So Hospital A may be using Apple software. Hospital B may be using Android software. Hospital C may be using Google software. And a lot of times, none of these softwares talk to each other. So yes, you may have been treated in Hospital B last week, but because they're using Android software, when you go to Hospital A to seek treatment, and you say, well, I was admitted to the hospital last week, but you weren't admitted in Hospital A would not have any clue of what happened. They would not have any clue of any change of medications. And so that's what a lot of times leads to frustration with people who admit to the hospital, like, hey, I was in the hospital. I don't understand why you don't know that, or you don't know the process that happened while in the hospital. Well, yeah, unfortunately, we all don't have the same software systems to talk to one another. So the best thing to do is, if you are in a hospital that you don't normally go to, at the end of your hospital stay, just ask for your records and keep that with you, especially if you go to any hospital in the future, so that they can see. That helps out the doctor a lot. And always make sure you have your current medication list with you because of that. And also because, when you are, whatever medications you are taking in your primary care clinic, and the primary care doctor gives you, a lot of times, again, that does not translate to our system, our software system. So sometimes we see that you're on drug A and you haven't taken drug A in years. And if you don't tell us, we'll put you on drug A. So it's just a good idea just to have your medication current. And then the next thing is always know your code status. I think a couple videos ago, I did a actual Q&A with Dr. Mercy talking about this. So you're like, what is code status? Code status is something that doctors always ask when you get admitted to the hospital. A lot of times, things go well in the hospital. You are there because, you have pneumonia and we just give you antibiotics, or we may have to give you oxygen for a little bit. And then you get better and you go home. And that's the end of that story. But sometimes, someone who comes in with that pneumonia comes in with severe pneumonia to the point where they're now requiring a lot of oxygen. And then all of a sudden, even with the high oxygen that we give them, even with the strong antibiotics that we give them, they don't get better. In fact, they get worse. And on occasion, we get calls from the nurses, oh my goodness, patient in room 103 is not breathing, or they have their heart stopped. So by that time your heart stops or you stop breathing, you're technically dead. And so we always have to make the decision whether to call what I know you guys have heard before, the term code blue. Code blue is when the nurse finds out your heart stopped and you stopped breathing, you're technically dead, and they page on the overhead that person has stopped functioning. And so the code status is important because depending on that person's wishes, if they say, yes, I want you to resuscitate me, I want you to bring me back. If they say yes, then a team of people will rush into their rooms. Half of them will go to their head and stick a tube down their throat and hook them to a breathing machine, while the other half will do what you guys see as chest compressions, pounding on their chest, trying to get their heart to start back up. So as a doctor, we always like to know what the patient's wishes are for things such as that. And so a lot of times before something like that happens, we always want to make sure that everybody is aware that that's a potential that will happen in the hospital. And we always want to ask, okay, if that ever happened, what are your wishes? So I observed that a lot of people in their older age, maybe 80s and above, they don't really want that. They don't want people pounding on their chest. They don't want to be on the breathing machine. So they say no. Whereas, the younger folks, they're okay with us trying to bring them back. But that's definitely something to think about, especially if you go to hospitals on a regular basis. If you find someone asking you in the hospital what your wishes are, would you want to be brought back? You know, be cognizant of, be cognizant of that being something that you would have to make a decision about on day one of your hospital care. The reason why we also ask you is because usually in the beginning of your hospital care, you're alert, you know what is happening. But if you get progressively worse to the point where you require heavy doses of oxygen, or you eventually heart stops and you stop breathing, obviously you can't give us that answer. Hey, do you want to be brought back? You can't give us that answer at that time. So we always like to ask everyone, doesn't matter if you're there because of pneumonia or you're there because you stubbed your toe. We always like to ask what your code status is. And another reason why you should also know if you want to be resuscitated is because if you don't answer that question, a lot of times that gets pushed to your family members. And over the years that I've been working in the hospital, I've seen that families are not in a position to want to make that discussion during life-threatening situations. In other words, if their family member is on the bed, not breathing, their heart is not pumping, they don't want you as a doctor to come in there and say, hey, so your family member is not breathing and their heart stopped. What do you want us to do? Of course, that's very scary for them. They're like, whoa, 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 whoa. Even if that family member may be a member that's, has metastatic cancer, and their life, their quality of life is poor. That situation of asking them, hey, do you want us to bring your family member back or not? That's not that's not a time that they, or a time or period that appears appropriate. So if you do not take control of letting us know what your wishes are, and then secondly, letting your family know what your wishes are, then you risk your family being traumatized when asked that question on your behalf. So that's that. Another thing is, don't get mad at the repeat. What does that mean? Well, when someone comes into the hospital, I'm going to use pneumonia because it seems like that's what I've been using, and they're short of breath, maybe coughing some, maybe has some fevers and chills, and they come into the hospital just like, oh, I don't feel good. So the first people that they meet is usually the nurses, and the nurses are like, oh, why are you here? And you to say, okay, well, I'm here because I have a fever, or coughing, and just not feeling good. Okay, and so like, oh, I'm sorry to hear that. Let's put you in an ER room, and the doctor will attend to you. So you're going to your ER room, and the doctor comes in. Oh, what brings you here? I hear you're coughing. Yeah, doctor, I've been coughing, kind of wheezy a little bit, having fevers and chills. So the doctor does some labs, does some imaging, and then comes back to you and says, yeah, all those symptoms that you have, it's because you have pneumonia. You feel shocked and like, whoa, pneumonia. Yeah, well, you have pneumonia, but we feel like you need to stay in the hospital, and we feel like we need to treat you. After treating you, you'll be able to go home. So you're happy with the plan, and you're going, to now the hospital, inside the hospital, outside of the emergency room, and into a room. Well, you're settled into this new room and this new bed, and another doctor comes in, and it's a hospitalist, and they are like, well, hi, Mrs. or Mr. So and so, just here to get you situated in the hospital now. I got to ask you a couple questions, and then we'll go over the plan. So the hospitalist starts off and says, I hear you have a cough. Can you tell me more about it? At this point, some people get a little bit perturbed because they're like, well, didn't I tell the ER doc that I had a cough? Didn't I explain all that? Didn't he write that in his notes? Are you guys not talking to one another? What's going on? So this is where I say don't get mad at the repeat because what usually happens is we already heard from the ER doc that you were coming in, and we got a synopsis from the ER doc, the reason why you're here. But um, because of the fact that sometimes what we people hear in general may not translate exactly to what they heard when they say repeat it, we always want to make sure that what you said to the ER doc is actually what it is. A lot of times when I confirm what I heard from the ER doc to the patient, they're usually like, no, I didn't say it was going on for a week. I said it was going on for the past 2 days. And no, oh, I didn't say I had abdominal pain. So we always ask repetitive questions that you may have heard before, just to make sure that we're treating you for the right thing. So don't get mad at the repeat, okay? That is the reason why it's being done. We want to make your stay productive and accurate. So that's there. And moving on, always know that there's a lot of behind the scenes that is going on with your care. So a lot of times when people get into the hospital, they only see a certain processes that's involved. So when you go into the hospital, you're seeing the nurse, you're seeing the doctor, you may see other people, but what you don't know is what's going on behind the scenes to get you from point A to point B. So if we use the pneumonia patient, as he's talking to the doctor and the doctor says, well, looks like you're going to get admitted, the doctor leaves the room and the patient's just waiting for a room. But what he doesn't know is the doctor's busy looking at the x-ray, calling the hospital, say, hey, I got someone here who needs to be admitted to the hospital. This is their situation. Oh, we should get the lung doctor? Oh, no problem. Then calling the lung doctor and saying, hey, lung doctor, there's a patient that's going to be admitted to the hospital. Can you please see them in the morning or see them later on? Then they may also look at the x-ray and say, you know what? Yes, that's a pneumonia, but let me do a scan to further look at that pneumonia, or let me do a scan because I'm seeing something else there. Then at the same time, they're also saying, well, not only are you here for pneumonia, but I noticed that your sugars are up. And wait, you didn't tell me you had diabetes. I guess I have to check that out as well. Or again, your blood pressure is elevated. Well, it could be because you're coughing. It could be because you're in pain. Let me order something for cough. Let me order something for pain. Or, maybe you have underlying high blood pressure that you didn't know about. See, these are all the stuff that's happening behind the scenes. Or the nurse may come in and say, oh, hey, doctor, this patient, oxygen level is still low despite me giving him oxygen. And then you're having to talk to the respiratory therapist. Hey, respiratory therapist, can you go into that room? Can you give him more oxygen? Because the oxygen level is looking low. So do you see, there's a lot of things that are happening behind the scenes. And while you're sitting in the room, just kind of waiting for your bed, behind the scenes, things are happening. So I say all that to say, there are things that are visible when you're in the hospital, and then there's things that are not. So when you see any delay of someone coming into your room, you think that, why are they taking a long time? It's because they're still working on your care. It's just, it may not be visible to you. So I've always made it a point to let my patients know, hey, thanks, thank you for your information. Let me just let you know, I already knew you were coming in. This is what I've already done. And this is what I'm going to do when I leave your room. So I make the invisible more visible to them, but not everybody does that. So I just wanted to make sure that you were definitely aware of that. Another thing is always ask for labs and imaging when you are being seen in the hospital. Don't be a stranger. If you need to know it because it'll help you out to understand what's going on, always ask, hey, can I see the labs? You said I had high levels of diabetes, or what's my blood sugar at this moment? Or you said I had a pneumonia. Can I see the x-ray? And a lot of times we'll be like, sure, a lot of the times there's computers in the room nowadays. And so we can be able to open up the image and show it to you. And we can show you the area in which you had the pneumonia. So don't be afraid to ask. That's something that we as doctors, we're happy when you want to know more about your care. So that leads into ask questions, just in general, ask general questions. Don't be afraid to ask. I love it. For me, I love it when patients are curious to know, but doctor, why do I have heart failure? What is heart failure? Can you explain? And I will explain away. I even open up the internet and get certain images so that you can see how the heart is, and a heart of a heart patient, how that is compared to a normal heart. I be 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 okay to ask. Part of our job is not only treating you, but acting as a teacher, helping you understand your body. Because if you don't understand your body, you won't be able to take care of it. There's only, when you're in the hospital, there's only a certain window of time where we are interacting with you. As you're getting better and as you go home, you're going to be the one that's going to be taking care of yourself. So, in order for you to do so, in order for you to be your own advocate, you have to know what's going on. So, we like to take the time to do that. So, well, that is, it looks like I'm past the 30-minute mark. That is it for now. I still have some more tips and that I would like to share. So I'll definitely do that at another time. But I thank you guys for coming in, and I hope you guys have a wonderful, wonderful weekend. And until next time, bye.